reasons. Could be following trauma, non-traumatic causes, which could include infections, non-infectious causes, which again can be because of disorders of the ocular surface or autoimmune conditions, and it could also induce various etiology, include chemical injury, dry eye, or exposure-related causes. So the first question that you want to ask yourself is there a systemic risk factor? History becomes very important because we know patients who are on steroids, who are diabetic, who are immunosuppressed, or have collagen disorders, or on massive immunosuppression and steroids, that makes the eye at potentiality for increased risk of thinning and perforation, and so it's very important to do a systemic stabilization of these factors. Sometimes you have patients presenting with bilateral perforations like this. Here again, you may want to rule out whether the patient is immunocompromised and is on massive immunosuppression. Now, the second question you want to ask yourself is whether the eye is at risk. As you can see here, patients with blue sclera can have perforation. Patients with ectatic disorders like PMD are easily prone for perforation. And then you also have patients with post-PK where with minimal trauma, which is directly into the eye, can cause risk of perforation of the corneal graft. Now here again you must remember these eyes are very difficult to close, so the cornea is very thin and tears like a paper. Therefore you may need to be ready with ancillary measures like cyanoacrylate glue or sometimes even a patch, but that becomes very difficult to suture again because cornea is very thin. Now again the question that comes to our mind when it is a post-PK perforation is, can you put the same tissue back? Sometimes depending on the quadrant, depending on the extent of tissue loss, at what point of time the patient is presenting to you, is there an infection or not? Based on that you can decide, but it's always better to keep a backup tissue unless you have a very small quadrant where you have a perforation and that there is no loss of tissue where you can try to secure it back. Here again beware of any infection in the post-operative period. Again, this is an eye which has an adnexal problem. As you can see, she has lagophthalmos, surface inflammation, lid is not okay. So these are the things that you want to address before you go ahead and take care of the perforation. Again, it could be related to unusual organisms. This is a patient with pythium. And the picture below is that of a rare organism called rhizopus, which travels from the sinuses to the eye. And so the diagnosis was missed for a considerable period of time. Another patient with post-CXL, which was referred, had Pseudomonas and Aspergillus. Again, patient perforated despite maximum medical treatment. So now let's go on to the next thing, which is the complaints. Quite often they have pain, redness, watering, but beware if the patient says suddenly there is a relief from symptom, you should be worried if it is perforated. Especially in infected situations, this is always a possibility. Now, like I said, take care of the systemic condition and see whether you're dealing with the inflammation, infection, or a sequelae. And what you have to also look at in the eye, other than what I already discussed, is about the size and location of the perforation, extent of thinning, is your status positive or negative, and if your AC is formed. All the manipulation have to be very done very gently, and along with the things that I'm going to discuss, remember the surface has to be stabilized. You need IOP lowering agents and may also want to use medications that will prevent the collagenolisis. Now, what is the role of imaging? Usually in these eyes, there is either a thinning or scarring, and therefore in these eyes you may use this or edema. So you may use this as a mark to understand whether the patient is responding to your treatment or not. As you can see, this patient has considerable edema. But in this case, again, is a patient with infection and thinning, where you can also see that apart from here there is edema, but you can see an endothelial exudate. So it also probably sometimes gives you a clue to the diagnosis. In non-infected cases, it is about the response to treatment in terms of scarring and how the thinning is getting progressively worse or better. Now, when you have something like this, patient presenting with a fingernail injury with desmetocele and a foreign body, you may have to do a general ultrasound to see if there is a foreign body inside, and sometimes CT scan may also be required. Having discussed the role of investigations, let's look at the options that we have. First thing is to do a good photo documentation and counsel your patients very well on what to expect out of these eyes. And remember, when there is a leaky wound, a desmetocele, sometimes when you close it, the pressure can become skyrocketingly high, and that becomes a very serious problem. So you have to counsel your patient regarding this as well. Quite often you can do away with local anesthesia, but the block has to be very gentle, otherwise it runs the risk of perforation. Of course, in eyes with large amounts of thinning, systemic problems, children, you definitely want to consider general anesthesia. Now let's look at the first option, which is a cyanoacrylate glue. For thinning which is less than 3 millimeters, you may want to consider cyanoacrylate glue. Again, in infective cases, if you look at the picture on the right, you have somebody who has a significant control of the infection and mostly the thinning that is there. And here again, you can possibly consider a cyanoacrylate glue with a word of caution. We know the properties that it inhibits collagenolysers, it has antimicrobial property, it induces vascularization, and it is a strong adhesive. But what then are the limitations? Before that, how do you apply this? Remember, if the eye is dry, then it is fine. But if the aqueous is leaking, you have to create a cornea-aqueous interface by injecting minimal amount of air so that it does not cause rupture of the perforation, because without that, the glue will continuously get dislodged. You put a small drop, you can tease it with either your needle or your spatula and put a contact lens on top. Let's look at what are the limitations. Here is the patient, it's almost 3 months, the glue is refusing to dislodge. This is because the surface is not yet epithelialized. So sometimes it takes a long period of time and the contact lens can continuously have drug deposits, and therefore you have to observe these patients very carefully and wait for the glue to dislodge. Second, in a case of infection, while on one hand it induces vascularization and you're really happy that there is vascularization that is coming in which can take care of the infection, sometimes the infection can progress because the contact lens will prevent the drug penetration and therefore the infection can worsen. Again, you see this patient, this is the patient that we saw recently where we did a glue. Patient came back on day 2 saying that his infection is progress. This is not the infection that is progress, just that the discharge is accumulated under the contact lens, and sometimes this can give an impression that once we remove the discharge, the patient felt much better. So there was no worsening, but sometimes it can worsen. Now, you must choose an ideal candidate. This is the patient who is having a chronic fistula. Here, if you put glue, the aqueous is going to continuously dislodge the glue. So, therefore, these patients also have chronic angle closure and they are not ideal candidates. In chronic fistulas, you don't want to consider glue. You may have to do a definite procedure like a tectonic keratoplasty. Now let's move on to the Tennant's grafts. We know we can use Tennant's graft up to 5 millimeters of perforations. The advantage is that it is autologous, does not have a risk of infection. It is inexpensive and readily available, and it is a temporizing measure. We used a lot of it during the COVID times and we still continue to use it. Here is a patient who is a known case of arthritis who has developed with corneal thinning, and this patient was glued by somebody and again patient continued to progress. So here we went ahead and did the Tennant's graft. As you can see, you can go 2 millimeter beyond the limbus. Try and make the Tennant's graft as thin as possible and take it slightly larger if it's a young patient because it can tend to shrink. Don't make it very thick. And when you put it back, you can either stick it or suture it, and sometimes it can induce a little bit of haze in the cornea, but in these cases you're not really so much concerned about the haze as much as of the progression of the perforation. What is the limitation? Here is the patient who's had a very bulky Tennant's graft which is disfiguring, and like I said, sometimes you can have opacities which can again make the vision compromised. Now let's move on to amniotic membrane grafts. We know that amniotic membrane graft has a lot of good properties in terms of epithelialization. It has growth factors and it also helps in minimizing the infection by having antimicrobial properties as well. As you can see here, you really sometimes don't want to use it for central perforation because it gets integrated and that can cause sometimes visually disabling problems. But as you can see here, it's a patient of sclerocornea who had thinning and PED. Here we went ahead and put multi-layer amniotic membrane graft and she did well along with tarsorrhaphy. Sometimes you have to combine procedures. This is a patient of xeroderma who had surface problems, lid margin keratinization, has a thinning and perforation, where we used Tennant's graft along with an overlay of amniotic membrane graft and tarsorrhaphy, and this patient did stabilize and we published this as well. Again, sometimes patients have significant exposure because of facial palsy. In this patient, we never really thought we'll get away with a glue, but on table we injected minimum air because it was a fresh perforation. We were able to reposit the iris back and put cyanoacrylate glue and tarsorrhaphy. And in this patient, we have removed the tarsorrhaphy and there is a scar. I am a little apprehensive about doing PK in this eye because of the poor corneal sensation. Now let's move on to patch grafts. This is a patient who had a post-viral melt. Obviously, I'm not too keen to do a PK in this eye at this stage. So I want to do something. There's a large perforation paracentral. So we decided to go ahead and do a patch graft. As you can see here, what you have to do is please examine the eye carefully for areas of thinning. Try and make your mark little away from the area of thinning. Here we did a 4 millimeter trephination. We did a partial thickness dissection. and then you can inject minimum air to separate the iris if it is at the area of the wound, and get your donor cornea thickness based on the thickness that you need. Sometimes if it is very thin, you can glue it and put a contact lens on top, and sometimes you may have to secure it. If it is a thicker graft, I prefer to secure it. Now what happened in this patient? This is a patient who was lost to follow-up, and the graft initially what looked fine. Look at this, the graft melted away and developed a secondary infection because of loose sutures. So you have to follow these patients very carefully, and sometimes have to remove the sutures as well. But as you can see, if it is in the visual axis, you have a scar that can be disabling as well. Now let's look at larger perforations. In infections, you probably want to do TPK. I'm not going to go into the details of therapeutic penetrating keratoplasty, but be careful with your block because there is thinning and it can perforate during your block if you're doing under local anesthesia. But let's look at tectonic patch grafts. This is the patient of acanthamoeba who had a perforation, and almost 3 to 4 months later after stabilizing, she came back like this. So she wanted visual rehabilitation. After counseling her for one important thing, not only the graft failure, for increased intraocular pressure, we went ahead and did the tectonic graft. Remember, these angles are compromised, so therefore the pressure can go up. That's exactly what happened. Although she recovered 20/40 vision over a period of time, despite best glaucoma medications, the graft failed. So it's important to remember, in chronically leaking wounds, sometimes the angle is compromised, and therefore you can have problems with the increase in intraocular pressure. Now let's move on to the last part, which is about the Gunderson's flap. As you can see here, we used a lot of it. Usually it is considered in patients where there is shortage of donor tissue, and sometimes when the eye has very poor prognosis and has a melt, where you want to just salvage the eye. Here you basically reflect the conjunctiva tenens and put it and cover it on the area. Idea being that you are just giving it a good vascular pedicle. As you can see, it does cause a significant amount of scarring, and that's exactly the purpose of the procedure. You don't want it to melt away. We have had patients subsequent to this where we have done ASOCT and found that the scar is superficial, where we have reflected it and managed to get away with the lamellar keratoplasty. But in most cases, if the prognosis is good and the eye is settled, you may have to do a penetrating keratoplasty. So I'm going to conclude by saying that in corneal perforations, it is very important to elicit a good history. See if it is circulated trauma. Is the eye at risk, or is there a systemic risk factor that you want to control? Make sure that all the ocular and systemic factors have been evaluated and taken care of if there are any. A good counseling is important because these patients may come back to you again and again with repeated MELs, even if the systemic disease is under control in a case of rheumatoid arthritis patient. So you have to do a good counseling, do a good photo documentation, and remember that your examination has to be very gentle, because I had a patient who was waiting for scraping. By the time we called the person, the eye is perforated because the cornea was very thin. So you may even consider patching these eyes if the patient is waiting, if it is very, very thin. Supportive therapy is very important. Choose your technique based on the size, location, and extent of perforation, and modify your treatment based on the progression and response to therapy. Remember that these patients can have IOP rise, and they are likely to be with you for a very long period of time. Thank you so much for your patient hearing.
Showed one end of the spectrum to the other, where and which perforation can be treated by what and which method. So for the benefit of the audience, I want to ask you one question, where you yourself mentioned that when there's a clean perforation, the approach will be different, and when there is a comorbidity, the approach will be different. So which of these cases, along with the primary method that you described, would you also do ancillary treatments like, say, punctal occlusion or tarsography as an adjuvant measure to make the perforation heal a little faster?
So I think you can probably divide this into ocular risk factors and systemic factors, because you have like the patient that I showed who had sclerocornea, who had ill-defined limbus. When there's a limbal deficiency, you definitely expect that, or there's a surface inflammation but you're forced to do a procedure, you definitely expect that the epithelium is not going to heal, and therefore you may want to consider, along with procedures for the eye, doing tarsography or punctal occlusion or preservative-free lubricants as well. Similar is the case when you have a systemic comorbidity which is not under control but you're forced to take up the patient, like a patient with rheumatoid arthritis who's having a bilateral melt. Even if you want the stabilization, there are times when you have to take them up immediately. So these are the patients where you definitely want to consider doing a tarsography, total or partial, along with punctal cautery and maybe amniotic membrane, depending on the case.
I have a small personal nugget to add regarding Tenon's patch graft. So the problem where sometimes the graft becomes bulky, or even more when you put it for a perforation, the perforation seeps into the pores of the tenon tissue, and on day one the graft that is flat becomes boggy and balloon-like later. So to solve this problem, what I personally do is, after harvesting the tenons, I take it a little bigger than it's required, like Dr. Rama said, but I do a little bit of controlled cautery on the tenons. Just use cataract cautery and do a little stamp like marks on the tenon. Solves two purposes: thins out the tenons, and because it's a cross-linked tenons, as I call it, it absorbs water lesser and that ballooning is lesser. So that's what I've learned from my experience. Anybody else in the panel has anything to add? Dr. Revati, Dr. Uma, Dr. Anita?
Gutters and flap, those things, I think they work better in, it's okay, it's not,
Okay.
better in anesthetic corneas, because anesthetic corneas often try to melt by themselves, and those cases I think they are.
Ma'am, do you also de-epithelize them and remove the limbus? They say you have to destroy the limbus while doing a Gunderson's flap. Do you practice that to prevent epithelial inclusions and cysts under the flap?
I haven't seen so much of that, but I've heard that the inclusion cyst can actually hamper it. So it's better to de-epithelize is what I think. So are there any further questions? Otherwise, I'd like to invite Dr. Radhika to speak to us about corneal scleral tear repair.
Good afternoon. Thanks to Dr. Rama and AIOC for having me over here. It's indeed a pleasure to be in this focus group meeting dealing with corneal emergencies. I am Radhika from Shankar Nethralaya, and I'm going to talk to you about what I think are my tips and trips for corneoscleral tear repair, which is a frequent emergency that not only cornea surgeons but even general ophthalmologists are likely to encounter. The ocular trauma scale categorizes based on a few factors like the extent of the tear, the presence or absence of infection, retinal detachment, the assessment of the problem, and gives out a score. This is important because sometimes we feel that a small tear can be handled by the resident, and only when there's a large tear involving the choroid will chip in. But in fact, these are small tears which have a good OTS score and require a lot of our attention, because the prognosis for vision is very good in small corneal and scleral tears. So when you see a partial thickness tear like this, it is very important to do a Siedel's test, because you can see over there in that cobalt blue picture that the fluorescence is getting diluted by the aqueous. So there is a full thickness component under the flap tear. But if it is indeed a partial thickness tear, then if it is undisplaced, then it heals spontaneously. So we can just watch with a bandage contact lens. But there are two situations in which I will intervene. If it is a child, then I would like to put some sutures, because you can't trust them not to touch the eye. Also, if it is a displaced flap like this was sent to us as a flap tear with an infection by somebody else. But from the experience with LASIK flaps, we know that when a flap gets displaced, it loses its nutrition, because the flap gets its nutrition from the bed. So this is in fact necrosis of the flap, and all the outpouring of the hypopyon is inflammatory. So what we did is remove the epithelium to prevent inclusion cysts from happening, wash the bed thoroughly, and we put the flap back, and without a drop of antibiotic, you can see the so-called hypopyon has resolved and the flap has healed. So displaced lamellar tears have to be surgically sutured. So when you have a full thickness tear like this, you have to clean the wound. The prolapsed tissue should be managed appropriately, as I will tell you, and the wound should be approximated in its edges. Never grab the corneal tissue in the edge of the tear. Only the edges and conjunctiva should be held for support, and never enter the anterior chamber through the wound, because we may be A, increasing the damage, and B, introducing infection as well. So when you have iris prolapse like this, the olden teaching was to decide depending on the number of hours or days or whatever it was. But present day we understand that if it is fresh iris tissue like this, we have to clean it thoroughly, not only for infection but to prevent implantation cysts from happening. But if there is fresh iris tissue like this, no matter what the duration might have elapsed, we can put back the tissue like so to avoid glare and glaucoma. But if the iris is macerated, if there is infection, then there is cause to remove the iris tissue before suturing the wound. So this slide shows us almost all the principles that we have to follow during corneoscleral tear repair, and I will quickly elaborate each one by one. So when you have a straight tear like this, it is possible to use either partial thickness sutures like in the picture above, or full thickness sutures like in the picture below. Each has its own advantage, disadvantage. Partial thickness suture, the rate of infection is less, but the wound edema reduces a little slowly because the posterior wound still remains a little open. Whereas when you have a full thickness suture, the wound gets approximated, edema subsides very quickly, but risk of infection is there. So partial thickness sutures are always safer. So when you have a straight wound, you know how to suture, but when you have a shelving wound, then you must remember that the suture bites have to be placed in such a manner that you create a box so that the distances are adjusted accordingly for better healing. So here you have you are seeing showcase 3 different situations. First is where you have a corneoscleral tear. We must remember to take the first suture at the limbus, which is the known anatomic landmark. Then you go ahead and suture the cornea, and then you progress suturing the sclera. The second picture shows the corneal suture part, where we take central bites which are smaller and peripheral bites which are longer in order to retain the original prolate shape of the cornea. And the last picture shows you, the last schematic shows you an angular corneal wound which can be intimidating sometimes, but the trick is to take a central suture at the fork and convert it into 2 linear wounds. So quite often the residents ask us how many sutures they have to take to cover a wound. The answer is very simple. We know that each suture holds as much of the length of the wound as its own length. So the answer would be to place as many sutures, giving a distance of 1 or less suture bite in between them. So when you have a tear like this, the bends are sutured first, then the ends are sutured, and then all the way in between. So when you have a star-shaped wound like this, again it's sometimes difficult to tackle this. So it is imperative that we take a ring or a purse string suture. You can take one or many of them and see what happens in the second picture. Immediately it converts the wound into multiple linear wounds. And then we can go ahead suturing each of them. Trick is to keep the central purse string of optimal tightness, otherwise it can lead to fish mouthing. So once the wound heals completely, then comes the question of suture removal. Again, people ask you, when to do the suture removal, because that entirely depends on the wound healing, which is affected by the type of the wound, linear, lacerated, age of the patient, whether any infection is there or not, tissue loss is there, how much steroid you've used. So I follow a very simple principle. When I take a look at the wound, I look at what I call as the healing lines of fibrosis. If you see that white sun ray like lines, then you know the wound is ready for the suture removal. If you have a doubt, then better to go alternate suture removal followed by alternate suture removal. So 1, 3, 5 you remove so that you don't have the risk of a gape on the slit lamp. And it is important to keep sterility in mind, because a single suture removal, especially in post-trauma situations, can set up a corneal abscess. So what to do with the scar? So we have used pros contact lenses a lot, scleral contact lenses a lot for keratoconus patients. How do these help? They help because there is a fluid reservoir behind the lens. It helps in the fitment for the contact lens person, it helps in the comfort for the patient, and the liquid lens gives clarity of vision. The same principle can be applied for post-trauma scars also. You'll be surprised to see how many of these people get a lot of good vision without any surgery at all. I always do this prognostication before advising surgery for post-trauma corneal scars. So coming to scleral wounds, the principles are slightly different. We know that the limbus followed by cornea followed by sclera have to be sutured in that order. We follow a 50% rule, which I will show you first. But sometimes a scleral wound can run very posteriorly, and you can close as you go, again as I will show you. Extremely posterior wounds, don't dig at them. You will cause damage to the the optic nerve and the sclera behind the macula. So you must remember Tenon's is very vascular in the back portion of the orbit, and under that this wound can be left to heal. And however well you suture a scleral wound, make sure you cover it with conjunctiva. Otherwise you would have sutured it nicely, it can get exposed to infection, or sclera can necrose without the vascular cover over it. Suture material can be vicryl or nylon as you please, or as your experience dictates. So this is what I told you. In the right hand side picture, you see a corneoscleral tear. Half of it is under the upper eyelid. The left hand side schematic shows you that when you take the first couple of sutures, we are used to trimming the sutures. Don't do that. Leave the ends a little long so that you grab at that suture and rotate the globe towards you, and you see immediately the wound becomes more visible, and then you can continue to take sutures. So this is the hand over hand technique of suturing radial scleral tears which run under the eyelid. So when you see a situation like this, where you have a hematoma, distorted iris, a black reflex at the pupil, you don't see a tear, do you? But you have every business to suspect one. So how do you deal with this? Hopefully this video will play. Yes, it is. So first you need to expose the tear. That is the very important step. Don't jump into the suturing, because you have to create space to do the suturing, and you have to create space to assess the tear first. So a lot of the conjunctiva and the tenons are opened up, and then you see the extent of the tear right now. Passive hemostasis works better. Don't chase after every vessel with the cautery. Central bite first for the scleral wound. The 50% rule is that now the wound has become 2 halves. Now you put central bites again for the 2 halves, and so on. So keep suturing in halves till the scleral wound is closed completely. Divide in equal parts and close. Each suture supports its own length, as with the case of the corneal wounds. The extreme ends have to be sutured. This is very important in scleral wounds. Otherwise, the hypotony will continue even in the post-operative period. It's a little difficult to bury the knots. Then you open up the AC and do a little bit toilet as much as possible. Don't be very aggressive in removing. Only the loose lens matter and the visible vitreous will be removed. And close conjunctiva on top of the sutured scleral wound to avoid post-operative necrosis. So what you're seeing over here is not the corneal tear with the iris prolapse. The cornea lies beyond the instrument. Here you're seeing a knuckle of choroidal prolapse. So it's very difficult even for experienced people to deal with this. We adopted a very simple technique of using just a blunt instrument like a vexil, and assistant is asked to push back that choroid with the vexil, so that you don't create a hole in the choroid or even a retinal hole or a detachment. So after you opened up the area of the choroidal prolapse nicely, you see that somebody is actually using a blunt tip to push back the choroid, and then the suturing starts so that you can zipper it close. Seems to be a very simple technique, but it's quite effective in dealing with large choroidal prolapse. You can see the zippered close wound now. So we have actually published this technique. So conjunctival tears we think are easier to deal with. They are also, but here it is very important to look for prolapse of the tenons. You can see the tenons very clearly when you put the cobalt blue filter with fluorescein in the pictures above, but in the pictures below you are not seeing it very well. It's important to recognize it and excise it. Otherwise, you can have a tenons granuloma once you close the conjunctival wound. That's an annoying problem. So this also can happen when you have conjunctival abrasion, where the circular area is there. You can see an area of abraded conjunctiva. This patient, believe me, was treated as episcleritis, conjunctivitis by everybody, and all the steroids and antibiotics were preventing that layer of conjunctival epithelium from healing. All it takes is put fluorescein and look like in the cobalt blue picture below, and you can see the area of conjunctival erosion. So like recurrent corneal erosions, recurrent conjunctival erosions are a lesser known entity which can happen after superficial conjunctival trauma. A word about foreign bodies. Rust rings can be left alone. Don't go digging after them if they are inert. Superficial foreign bodies can be removed in the slit lamp itself. If you have deeper foreign bodies, then I tend to use what I call as the trapdoor technique. The schematic over there shows you, the ASOCT shows you the depth of the foreign body. The schematic shows you that you create a flap like a trabeculectomy flap, but this is on the cornea. There are two advantages to this. The foreign body immediately becomes visible. You don't have to dig at the foreign body when it is deep. And while removing, even if there is an accidental perforation, all you have to do is to put that flap back and suture, and the globe is intact immediately. So the trapdoor technique works very well for deep foreign bodies in the cornea. If there are multiple foreign bodies like this in a gunshot injury, again no need to go digging. As long as they are not extruding or getting infected, we can keep watching them, because going after each of them causes more damage and harm than good. So the incident of trauma changes the life of a patient in an instant. But there is only one good thing about it, because the tissue is usually healthy tissue. It's not diseased tissue as you deal with in other situations. So quite often you can do just a repair job. But when there is extensive corneal tissue loss, or when the pies of an RK are coming in your hand, or when the LASIK flap get lost, then you may need to resort to doing lamellar or penetrating keratoplasty. We have published penetrating keratoplasty as a globe-saving procedure when a fragile cornea or a brittle cornea succumbs to injury. Lastly, when you have a healed corneal wound, which is a very severe scar, you need to do a keratoplasty. But quite often you can see the sequence that's happening. The wound is there, the repair is done, the scar is there, we've done a nice graft, but then because of plenty of membrane formation, why? Young patient with heme and inflammation behind the cornea, it causes membrane formation, and the graft which looks good on table fails, as you can see in the last picture. So we have published a series in which even if there is no retinal complication, like no retinal detachment or no foreign body, even then when there is extensive inflammation in the posterior segment, when you do a penetrating keratoplasty, if you combine it with a pars plana vitrectomy, then it reduces the membrane formation, giving a longer life to the graft itself. With that list of differentials, I close my presentation. Thank you so very much.
Excellent comprehensive review of trauma. Any questions from the audience? So I would like to add a quick comment to this. I think all cases were beautifully managed, but there are some cases where you may have loss of tissue, and whether it is a case of blue sclera or otherwise, if the trauma is very intense, there things become totally different. You have to remember that you might need other procedures, like sometimes glue over the suture, or sometimes even patch grafts, which make things very difficult. The second thing I think is it's equally important. While primary repair is the most urgent thing that you want to do, remember these patients are at risk of infection, because most of the times the injury is with foreign bodies, so they are at high risk of endophthalmitis or retinal detachment, choroidal bleeding. So as soon as the wound is stable, it's important that you get a gentle ultrasound done and refer these patients based on the findings to your retina colleagues, because early repair of these comorbidities can go a long way in giving very good anatomical and functional success. Any comments from Dr. Umar?
What do you think? Should all the corneal tears be managed only by cornea people, or it's a very contentious question? So in the multi-speciality hospital, the oculoplasty guys are asked to suture the lid, especially when it involves the margin and canalicular damage, and the others don't touch it. Similarly, a corneal tear, which has got the ones which Dr. Radhika showed, first string type or flap type or tissue loss type, do you think it should be handled? And the other part of the question is, if it extends beyond the cornea into the sclera, into the posterior part of the globe, should the retina guys be involved?
So
I
I,
answer that
yeah,
question?
she wants to answer that. I will.
So the answer is both yes and no. So I believe that nobody can take care of my child as well as I can. Okay, so I would apply the same principle to the cornea as well. But then practically it's not going to be possible for a bunch of us to, stay night after night and do these procedures. The respect that we accord to the cornea, no offense to anybody, any other specialties. I know only so much about the dealing with retinal problems, so it's the same for others as well. But the respect that we accord to the cornea, to the epithelium, to the opposition, to the healing, to the suture removal, I don't expect other specialists to do that. But then when there are situations in our hospital, what we follow is, when there are situations where they cannot handle, like you rightly said, a purse string suture or a fragile cornea or a flap tear with a leak underneath that, or a stellate corneal tear where they cannot manage because of lack of experience, then we pitch in. But if it is a straightforward injury, then our colleagues are able to do it. But that said, I reiterate the point I said on my first slide, that it is these simple corneal tears that have an excellent prognostic score. And all of you would agree that these patients almost, come back to normal vision later. So I think, it should be justified with proper interest at the time of the treatment as well.
So coming to the canalicular tear, I think in our institute, apart from the primary repair, the canalicular tear is managed by the oculoplasty person then and there. So we have a team, so we request them to come. So we don't schedule it, we do it simultaneously. And when there is a corneoscleral tear, if you are able to see the posterior extent, we do it as much as possible. If we feel that it cannot be done beyond that, then we refer the patient to the retina colleague. So with that, I think I would like to request Dr. Revati to speak to us about the corneal infections and comorbidities.
In addition to that, the situation may be like, when not in a multi-specialty hospital, standalone practitioner, when they come across injuries, there also we should think, but no harm in they can attempt a primary repair, but as much as only possible, and then refer the patient to a higher center where all specialties can take care of the patient. Thank you, Dr. Rama, and especially for thinking about this topic, because often this is a missed topic, or even in symposiums or ICs, where corneal infections alone they deal with the importance of comorbidities. So it's quite important and very difficult to manage these cases, case of corneal infection when there is a comorbidity, especially if it is a systemic one. The comorbidity can be ocular also, but a systemic one always a problem, because in presence of infection, often this the systemic therapy itself can intervene with the management of our infection as well as the wound healing. I am going to talk mainly on based on case examples. This is one case where a patient presented with almost a subtotal big ulcer and found to be acanthamoeba, and he is an alcoholic already, and also in addition a diabetic, uncontrolled diabetic. So we needed to admit him with the insulin and other things. We have to really struggle to bring the blood sugar level in control. But what had happened with the treatment itself, even within 10 days, he developed anterior scleral involvement with massive chemosis, and also we can confirm it with subtenon fluid in the B scan, and also UBM showed the scleritis very clearly. And so now the question is whether to add topical steroids. We have not gone for any systemic, but we have added topical steroid, but the condition worsened further, and finally we have decided that we have to go and remove the infected tissue. So we went for a large corneoscleral anterior scleral graft, and as you can see, even after the graft, gradually this chemosis came down a little bit, but the patient has become NLP and later found to be funnel RD, and also it has become thicical, but still even the B scan was showing the subtenon fluid posteriorly for a long time. So finally, when we decided to stop even at one stage we were even thinking about going for evisceration, because he's a diabetic still was fluctuating and whether to leave it like that, and then finally he went in for phthisis, and once we stopped the biguanide, the subtenon fluid disappeared. We don't know whether there is a toxicity to the drug also. So this is a case which I have seen in a series of cases of acanthamoeba as a first one. So at that time I thought mainly his diabetic status was the problem for the worst outcome. But later, even in healthy young patients, a series of acanthamoeba we have come across where they have gone for scleral involvement in very soon, like within a few weeks, and gone for very even later chronic hypotony, phthisis, and some of them we prevented by doing vitrectomy and silicone oil injection. With all the struggle, we were able to maintain the globe. But this is a series of infections. I don't know of late whether you people are coming across such severe acanthamoeba cases. Previously, we never used to come across like that. And so here, as scleritis in acanthamoeba can be inflammatory and immune mediated, so we should not hesitate to start steroid here, even in the presence of acanthamoeba infection. Whether to go for even systemic steroid, that depends. But in a presence of comorbidity like diabetic, we may not be able to do that. And also, like toxic reaction to the drug also we have to keep in mind. Many of these biguanides, especially nowadays, very high concentrations like 0.08% and all were recommended, and we have to keep those things also in mind. The case number 2 is almost like what Dr. Rama showed, corneal thinning which was managed with 3 antibiotics and 1 antifungal, and came with large yellowish plaque-like thing over it, over the thinned area. And the patient was known thyroid disorder patient as well as seronegative arthritis using sulfasalazine. And then the more important point is the periocular skin was eczematous and darkly pigmented. I was congested like anything, so I thought it must be more of a toxic reaction to the drug. So I stopped all the drugs. I thought it may be simple arthritis or rheumatoid arthritis related sterile melt, and went in for only using topical lubricants. Within a few days the skin improved very well, and then we have gone for a tenoplasty, and then later the patient recovered, of course, It was not in the visual axis, so I didn't even go for any grafting or anything. Now the patient is holding very well by continuing her systemic medication. So here again we have to think any case of something really patients using immunosuppressants or NSAIDs for their other systemic problem. If they come with a corneal melt, don't think it's only infection, and we have to think about it and manage, balance the treatment. And the real adversity, I am going to give an example now. A 52-year female, otherwise healthy, but she is suffering from immune nephritis, for which she is on treatment with methotrexate as well as low dose steroid for a long time. And she had a bout of conjunctivitis some few months back, and then when she presented, on one eye she had this lesion. Initially it was suspected by somebody else as only subepithelial keratopathy after EKC, but you can see the granular cloudy appearance, which is more suggestive of microsporidiosis. And we did a confocal which showed very clear, like a histopathology, the rice bodies inside the cells, and so we have gone for the diagnosis of this microsporidiosis, and then started these treatments. As you can see, even with whatever, as you know, my personal experience, microsporidiosis stromal very rarely respond to topical therapy, and now you can see it's going up to the limbus. The lesions were going up to the limbus, and she is on immunosuppressant. So at one stage we have, and the ASOCT showed only a superficial stromal, up to mid-stromal level involvement only. So we have gone for therapeutic DALK, and after explaining that recurrence is possible because I need to do almost limbus to limbus grafting. And then this was the initial picture, very encouraging. Vision was 618. She was very, very happy, and the histopathology confirmed our diagnosis of microsporidia. But after a month, gradually the interface, some lesions started, gradually keep on increasing, vision dropped, and not only that, in the left eye she developed some lesions which were gradually increasing, and even you can see the KPs and other things in the anterior ASOCT. And by this time we were talking with the nephrologist whether he can tamper the immunosuppressive drugs, little bit. But when he was considering that only, she developed a bout of hematuria. So he declared that it is not possible, and then he was continuing the therapy. Luckily, like after some time, like she became kind of stabilized, and she kept on asking the right eye, because it became more and more cloudy, now vision again dropping. She was requesting for another surgery, like that, but I was very hesitant because she is still on immunosuppressant, going for even a PK, limbus to limbus. Again, not only failure, secondary glaucoma, and the secondary infection, again reinfection. So by the time I was even considering fumigalin, as reported by Dr. Baga, but it was very difficult to get and also very, very expensive. Then tablet albendazole I started thinking, like, it is not very expensive, I can give it a try after getting her nephrologist clearance. And now what we are doing is only giving albendazole along with the other medications, and I can, maybe it is only my expectancy that I can see some kind of a scarring in the periphery. Even in the left eye I can see some kind of a scarring. So I hope that, crossing our fingers, we are waiting. And again, the last week again she has gone for another bout of hematuria, and doctor again increased the methotrexate dosage. Now I don't know what is going to happen. We have to wait and observe. These are the cases with comorbidity. Corneal infections will be very challenging. Often we need to talk with our colleagues in the other specialties hand in hand, and we have to try to manage them. And this is borrowed from Dr. Radhika, one of her publications, I think. It's a lichen planus with the infection. So when this pannus occurs in the periphery, generally in an infection we expect a better outcome, but the corneal thinning was increasing. So she thought, because it's an immune problem, maybe the immune mediators are more causing the corneal thinning. After removing that pannus, actually the healing was much, much better. So in these cases we have to think about other ways of, we have to always keep our mind open with the lateral thinking. And coming to the ocular comorbidity, any infection in already corneal scar or a graft or anything, mostly bacterial, mostly strep pneumo or staph aureus, and we have to keep that in mind, and we have to, in these cases, we may need to go for add steroid along with the antimicrobial therapy. And this is another condition we come across often, neovascular glaucoma or absolute eyes which were treated with steroid for a long time. Suddenly they will come with a breakdown and a big full thickness abscess kind of thing. Often it will be mistaken for a fungal infection and bombarded with antifungal therapy, but this is mainly more of a exotoxin reaction, a posterior corneal abscess. You have to continue the steroid along with the antimicrobial therapy, then gradually they will recover. Of course, we have to keep in mind the trophic component also in managing any infection with the comorbidity. So the conclusion is, especially systemic comorbidities are really challenging in the presence of an active infection. We have to try many different techniques and different approaches for this, and we have to co-manage along with our colleagues in the other specialty. And ocular comorbidities should not be missed out. Trophic and other components, as already discussed, that also we have to keep in mind and manage. Thank you.
Ma'am, I have a question for you. So another common situation where we have issues is combination of diabetic patient, herpetic stromal nephrotic keratitis and deranged renal parameters. Quite often they also have diabetic nephropathy, and because of the immunocompromised condition, the herpes also flourishes. So how do you control or titrate your oral antivirals in these cases?
Yeah. Again, we have to rely on the nephrologist, this thing. I have used long-term even oral antiviral in renal transplant patients, where the nephrologist used to be more comfortable now allowing us to continue. But in the presence of a compromised renal function, always, that's a very, very tricky thing, like, very difficult. Yes, you just scrape, nothing will come, sometimes very few bacterial thing only. It's more of a, what that terminology we used to read in our days, olden days, posterior corneal abscess, which is only a reaction to the exotoxin from the bacteria, not the endothelial plaque, which is an active infection in a case of fungal infection. No, this is very clear. These were very chronic diseased eyes, many of them NLP, and they were on steroid for a long time. And if the infection occurs in such an eye, if it is a fungus, by this time you would have gone for evisceration. So it's logical thinking, and then gradually, and then you, of course, the scraping, nothing will come, and then you add and see. Yeah.
So excellent cases. The only thing is I have, yeah, please go ahead.
In one case you had pannus, and after removing that, did you go for therapeutic keratoconus?
Actually, that case was borrowed from
No,
Dr.
that
Radhika.
case was mine, and that's an exception, not the rule. There's a child with lichen planus, a teenager, and she developed an incidental bacterial infection. It was not because of her primary infection. She was well controlled with her rheumatologist. We scraped and we found bacteria, and then it was resolving to the antibiotics also. When the pannus came in, normally the pannus comes in and the infection heals because of the vascularity. Here, paradoxically, the melt increased. When the infection was active, there was no melting. When the pannus came, the melt increased. Then when we recessed the pannus, there are still some follow-up pictures. Then the drugs worked very well and she scarred completely, no TPK was required. But that is an exception, not the rule. We don't recess pannus in infectious keratitis, that is not the message here.
Can we go for therapeutic?
No, in the sense the need for therapeutic will be like in any other case. The lichen planus need not influence your decision about therapeutic PK. If it melts or extends, then you do therapeutic. If it responds, then you don't do the therapeutic.
So I think very excellent cases. The take-home point is that whenever you have somebody with chronic immunosuppressive medications, you always expect to have virulent organisms which are normal but can be very virulent in their presentation, or it can be unusual organisms like candida, yeast, or otherwise also. So if you're doing a procedure, it may be well worth considering sending the sample for histopathology and microbiology, because sometimes I'll be presenting that on Sunday. There are cases where histopathology has picked up something where because of the possibly the area was not representative of other things, the micro did not give us. So we'll go on to the next talk by Dr. Uma on managing acute chemical injury.
Thank you, Dr. Rama, for inviting me for this IC, which had brilliant talks earlier.
This acute phase management of chemical injuries, I think all of us do. I'm just reiterating some facts which we already know. It's not moving. Yeah. It's not Chemical injuries of the eye may produce extensive damage to the ocular surface epithelium, cornea and anterior segment, resulting in permanent unilateral or bilateral visual impairment. 80% of ocular chemical burns are due to industrial and occupational exposure. Usually males more than females, but acid throwing and all are usually on the females. Lime burn, tuna is very common, whitewash or also tuna packets which are commonly used. Now acids which are the sources of acids would be sulfuric acid, which could be battery acid, which we find in a lot of patients. They come with battery acid injury, ammonia, alkalis like ammonia in fertilizers, refrigerants, cleaning agents, acetic acid like in vinegar, glacial acetic acid, that is household products that we are using, lye that is in drain cleaner. A lot of patients come with harpic injuries. Hydrochloric acid, sulfurous acid in the labs, lime in plaster, mortar, cement, whitewash, hydrofluoric acid in glass polishing and etching, and potassium hydroxide, magnesium hydroxide in incendiary devices. And cracker injuries can cause thermal as well as chemical burns. The acid injuries, they cause denaturation, precipitation of proteins on contact with a ground glass appearance, and they cause a barrier to penetration. And alkalis cause deeper injuries because of saponification of fatty acids in cell membranes and cause damage to deeper structures. The injuries, we should treat the chemical injuries so that this picture does not become like this picture. So acute management is extremely important. At the site, whatever solution is available, tap water is hypotonic, but whatever is available has to be used. Normal saline, ringer lactate, BSS, polyvalent amphoteric solution like diphoterine are of course preferred, but anything excessively it should be washed. Now if you have access to a Morgan lens, you instill a topical antibiotic and anesthetic drop, connect the lens delivery system to an IV tubing system, retract the upper lid, put it and then thoroughly wash, and then make sure that the neutral pH is achieved. So it's good to have pH strips with you. Alkalis cause max damage in the pH between 11 and 11.5. They dehydrate the cells and they destroy the structural proteins. Ammonium hydroxide is the worst, followed by sodium, potassium and calcium. Heat generated by chemical reactions will cause additional damage. The ocular response to chemical injury, conjunctiva becomes cauterized, corneal epithelium sloughs, stroma swells and opacifies, endothelial cells die, angle structures scar and lens opacifies. So the ocular response, the weaker acids and alkalis, they cause injection, chemosis, mild corneal clouding and edema. Severe acid burns, the conjunctiva and cornea are white and opaque. In nitric and chromic acid, the tissue becomes yellow-brown. Severe acids can cause corneal anesthesia, limbal pallor, uveitis. Severe alkali can cause corneal melting and perforation in 2 to 4 weeks. Extent of rimbal injury is also important for re-epithelialization. So to manage the acute phase, you have to use either whatever is available on the site. Tap water is ubiquitously available. The buffered solutions can correct the pH. The purpose designed solutions are isotonic to the stroma. Amphoteric solutions, if they are available, they are hypertonic, rapid pH correction, faster re-epithelialization. So given the importance of prompt and continuous treatment, the most immediately available and sufficiently abundant solution should be utilized. The clinical course of chemical injury, the determinants are the pH, concentration, and the length of time of contact. And the phases are immediate, acute, early, and late reparative. Immediate phase up to a week, there is tissue necrosis and sloughing. Intermediate phase 1 to 3 weeks, ulcers, melts, vessels, recanalization, hemorrhages, and pannus formation are seen. Late phases after 3 weeks up to several months will show either they heal or don't heal with pannus, persistent epithelial defect, perforation, neurotrophic changes. So, and the late reparative phases, as you see, severe injury is leading to pannus formation, but the aim is to maintain epithelialization and have a wet surface. The key elements for prognosis are the total area of corneal epithelial defect, the area of conjunctival defect, the number of clock hours of limbal blanching. Here one must say that the picture keeps changing. White is of course not good, red is good, but hemorrhages if you see and the clinical picture keeps changing. I think LVP did a study where all cornea specialists were asked about limbal ischemia and there was a lot of variation on how people perceived the limbal ischemia. the area and degree of density of corneal opacification, evidence of increased IOP on presentation, especially if resistant to treatment, and any loss of lens clarity. The last two elements imply deeper effects of the chemical agent and damage to the inner ocular structures. So the principles of management, I think all of us know, we just have to reiterate, is to prevent further damage, assess properly, control acute inflammation, facilitate healing. One thing which has to be reiterated here, that people do not give steroids if there is an epithelial defect. This is a total, I think it's something which you don't do where there is epithelial defect or no epithelial defect. If there is there is inflammation and chemical injury, one cannot avoid steroids. Maybe we'll argue, are you giving Predfort or softer steroids? But there is no argument on whether you're giving steroids or not. Of late in Delhi at least, we had a lot of holy colors injury. Luckily, they were all mild. Nobody used paint or tar or cement and stuff like that, and eggs and stuff. But a lot of patients came with epithelial defects, and a few of my colleagues, even cornea colleagues, did not give steroids, which I thought, and the patients had severe inflammation. So one should remember that steroids is an important part of the whole thing. Treatment and evaluation, this is one thing I have procured from Amazon, and I always have it. pH strips, I also check drugs also for when they have drug toxicity. But this is one important, thoroughly available everywhere. When you check the pH in the after the eye wash, you also evert the surface. We don't have access to OCT Octa. There you can see the limbal ischemia here, and which improved after tenonplasty. So if you have access to Octa, then it's great. Then clinical, one of our colleagues, Dr. Bhaskar Roy Chaudhary, had done a software in which the clinical picture could be seen of the vascularization, which was, I think, he has not patented it yet, but it's a software which he has developed. Clinical classification of chemical burns are important. The eye burns are classified in 4 grades, and several classifications like Reams, Hughes, Roper Hall's classification. Recently, we had Dr. Dua in Delhi for a talk. So I did happen to ask him whether he combined his classification with any other classification, but he said he only follows his own classification. So I would like to ask the panel later on what they follow. The classifications are based on total corneal epithelial defect, area of conjunctival epithelial defect, number of clock hours of limbal blanching, corneal opacification, evidence of increased IOP, and loss of lens clarity. So you have the RALS classification with the prognostic points. Then you have insignificant would be 0 to 3, where it recovers very well. 4 to 6 would be mild. 7 to 9 would be moderate. 10 to 12 is severe, and more than 13 is worse. You also have the Hughes classification, where you have mild, moderately severe, and very severe. And then you have the Thorp's classification, like grade 1, it says epithelial damage, good prognosis. Grade 2, cornea is hazy, but you can see the iris details, and ischemia less than 1/3 limbus, which is also good. Grade 3, loss of corneal epithelium, stromal haze blurs the iris detail, guarded. And grade 4, very severe, poor prognosis. Now, all these classifications are never the conjunctiva is mentioned. I'm sure that's why Dr. Dua came with his classification. Roper Hall's and modified Roper Hall's classification is what we used to usually follow before the Dua's classification came in. The grade 1 and the grade 2 are good prognosis, where you find that there is no limbal ischemia in grade 1, less than 1/3 in grade 2. Grade 3 and grade 4, there is a lot of epithelial stromal edema, iris details are blurred, and there is limbal ischemia in grade 4 of more than half. But Dua's classification goes into grade 5 and grade 6 too, where you can see that conjunctiva is also, you see the 0 clock hours of limbal involvement, less than 3, 3 to 6, more than 6, less than 9, and then guarded and very poor are the 5 and 6, which are not there in the other classifications. And you also have the analog scale, which records accurately the limbal involvement and clock hours of affected limbus divided by percentage of conjunctival involvement, but you only go up to the fornices and include up to fornices. So here you can see there is no ischemia here, and less than 3 clock hours of corneal, less than 30% conjunctival. Here you can see more than 3, less than 6. And then you can also see that more than 30 and less than 50% of conjunctival involvement. Grade 4, you can see more than 6, less than 9 clock hours of involvement. Grade 5, you can see here more than 9, less than 12 clock hours of involvement. And grade 6, 12 clock hours of corneal involvement, 100% of conjunctival involvement. one thing I did ask Dr. Dua was your classification is not telling us about the corneal opacity and about the the iris and the lens and all that, but then he said that he only follows his classification, does not combine it with any other. Here is an example of aluminium, molten aluminium falling into the eye, and all these cases are an emergency, like no emergency, like I think the only thing that qualifies similar is a CRAO or something like that, or an acute glaucoma. So all the residents need to know that we need to remove the tuna particles, we need to invert the lid, stop further damage, promote epithelialization, promote corneal repair and minimize ulceration and reduce the inflammation. So prompt irrigation, immediately anesthetic drops are put, passive opening of the lid, ask patient to look in all directions. All these we know, but it's just reiterating the whole thing. Wash all aspects of conjunctiva and cornea. You can also use cotton tip applicator and 1% EDTA to remove lime particles. Now the American National Standards Institute says at least 500 to 1000, of normal saline, Vinger lactate, BSS, BSS plus. Avoid water if possible. If it's in an institutional setting, of course, you can avoid it. Diphotherine, if you have access to it, pH of 7.4, binds acids and alkalis. Till the pH, you use the universal pH indicator paper, debride the necrotic cornea, conjunctival epithelium, subconjunctival tissue to remove the nidus of continuous inflammation and release of proteolytic enzymes. If the patient is in a state that you can evaluate the visual acuity and the pupillary reaction, see the facial skin, eyelids, lashes, lacrimal apparatus, torchlight examination if it does not allow on the slit lamp, epithelial loss, corneal opacification, limbal ischemia, white eye is worse than red eye, limbal ischemia, cloacas or blood vessel loss of conjunctival tissue where it nears the peripheral edge. Here again I must say there are a lot of variations in each person's examination and analyzing, and it's very dynamic. One day it might look white, the next day it might actually look a little more red when the vessels have started coming in. So one cannot on first day itself say that there is so much ischemia. Fluorescent staining shows the corneal epithelial loss. Obviously it can be a limbus to limbus loss, and then you may see that there is the staining is only on the edges. Then you may think that there's no epithelial loss where there is a total epithelial loss. IOP digitally or with a tonopen, you can do posterior segment evaluation, medical management. What is the aim of medical management? Promotion of re-epithelialization. Any epithelium, even conjunctival epithelium, is better than no epithelium. Tear substitutes, preferably preservative-free, bandage contact lens can be put. Investigational drugs, like now some of them are not really investigational. Fibronectin, growth factor, amniotic membrane suspension, autologous serum. Ascorbate, one most important thing is to give 2 grams QID is the ideally textbook thing, but one has to. And the other thing here is, one is told that in the second week, that is the intermediate phase, there will be continued melting, but most of the publications and even the textbooks say that if the AC has lot of ascorbic acid, there will be no melt. So better to give lots of ascorbic acid. You can continue to give the steroids in the intermediate phase, according to me. Sodium citrate also prevents the polymorphs from coming in, so their collagenases and elastases are prevented. Tetracycline or doxycycline also reduces collagenase activity and polymorphonuclear leukocyte activity. Cysteine, acetylcysteine, sodium and calcium EDTA and penicillamine are theoretically used. Acetylcysteine can be used. Topical autologous platelet-rich plasma eye drops promotes epithelialization faster than standard therapy. The role of topical ascorbic acid, if you can prepare 10% ascorbic acid from the injection, you can use that, or you can use lots of oral ascorbic acid. So here's an algorithm here. So you can see that you start the medical management in suspicious areas of ischemia, reperfusion if it is noted, no surgical intervention. If there is ischemia, you can do a permanent tarsorrhaphy to reduce the exposure, and then sectoral tenoplasty and AMG can also be used. With total ischemia, total 360-degree tenoplasty and AMG, and delayed presentation, you can see that you can do a tenoplasty here. Corticosteroids, they decrease the first and second wave of inflammation, stabilize polymorphonuclear leukocytes and lysosomal membranes. And NSAIDs can be used, but with preferably corticosteroids. Sodium citrate is a calcium chelator, inhibits collagenase. Prophylactic antibiotics, cycloplegics, and anti-glaucoma medications. Surgical management would include debridement, amniotic membrane, tenoplasty, And AMT in acute burns within 1 week. When do you do it? Within 4 to 5 days. If it's not healing, then it can be performed in the acute, early, and late reparative phase. And it's usually our first tool to decrease inflammation, promote healing. And here you can see a thermal with chemical burn with AMT did pretty well. This is another patient who had hydrogen peroxide, fell in the dye factory, fell on his face, and you had corneal emphysema. Then AMT was done. This is a small, I think we'll skip the video, small AMT. So tenon's advancement is another. The necrotic tissue is removed. As Radhika said, the posterior tenon is quite vascular. So you can do a tenonplasty, and there are several examples of tenonplasty where there is lot of, when there is limbal ischemia, tissue adhesives can be used. Alloslet has been used by the Shankar Netralia group in bilateral chemical injuries. So a thorough wash, removal of all particles, anti-inflammatories, high doses of ascorbate and citrate, control of IOP, and don't leave the tuna particles. Do not give topical steroids. Thank you.
Thank you, Dr. Uma, for a very comprehensive presentation. Are there any questions? We have time for one question.
And as she said, even after 2 weeks, I don't stop them abruptly. I use it.
And I think in the interest of the postgraduates or fellows who are here, it's important to really stain these eyes properly, because with ischemia, you may not really able to find it. So when you stain, and with the tears, it may get washed off. So stain properly and check for conjunctival ischemia. I would like to thank all of you for being a part of this session, and the moderators for excellent presentations. Thank you.